Great. Welcome to A Physician's Duty to Treat, Rethinking Medical Ethics in Carceral Spaces, the second of the four-part event series entitled Medical Justice in the Carceral State. My name is David Knight, and I'm a research associate and justice fellow at the Edmund J. Safra Center for Ethics. It is a great pleasure and privilege to welcome each of you to our discussion today. Before we begin, a few things to know. Closed captions are available through the Zoom captioning functionality. Feel free to turn them on if they would be helpful to you. In addition, please post any questions you have for our panel in the Q&A feature as they occur to you during the discussion. We will get to as many of them as possible towards the end of the event. Finally, we will be posting a recording of this event on our website within a week. So with that out of the way, we can begin. So on behalf of the Edmund J. Safra Center for Ethics, I'm happy to present this event developed by our Justice, Health, and Democracy Impact Initiative and the Medical Justice Alliance in cooperation with our Harvard co-sponsors, the Harvard FXB Center for Health and Human Rights, the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School, and the Office of Equity, Diversity, Inclusion, and Belonging at Harvard University. The Justice, Health, and Democracy Impact Initiative, or JHD, is a collaboration of Harvard's Edmund J. Safra Center for Ethics, the Brown School of Public Health, and New America that brings practitioners and academics together to create policy solutions for urgent problems. The Medical Justice Alliance is a new organization that seeks to protect incarcerated people's right to healthcare. It does this by providing pro bono physician expert testimony and legal claims involving incarcerated people. With over 100 physician volunteers and completed cases across the country, MJA is the largest clearinghouse for physician experts. MJA envisions a country without discriminatory healthcare access in the carceral setting. And to that objective, this event series, Medical Justice in the Carceral State, aims to encourage collaboration between the health and legal experts, raise awareness about healthcare disenfranchisement in carceral settings, and showcase the material change that is possible through public interest law and medical partnerships. In this second panel discussion in the series, the conversation will cover legal remedies for those experiencing health concerns in carceral settings, the need for expert medical witness testimony, and introduce the obligation that healthcare providers have to provide care beyond the bedside. And because our language frames how we think about these issues, we want to briefly underscore the need for intentionality in how we talk about restoration and the many lives and communities it impacts. While there may be a range of perspectives on this matter, we want to acknowledge the humanity we share by using people-first language to describe people with lived experience. For example, using phrases such as a person who is incarcerated or a person who is systems impacted rather than other terms. We also recognize that justice is all too rarely realized through the current legal system in the United States, leading many of us to prefer to describe the system as the carceral system or criminal legal system. I'm now pleased to welcome our panelists and moderator for this discussion. Liz Matos is the Executive Director of Prisoners Services of Massachusetts and was a staff attorney with the organization for over 7 years. Liz has been involved in litigation about solitary confinement practices regarding prisoners with mental illness, discrimination against deaf and hard of hearing prisoners, draconian classification practices, guard on prisoner assault, and lowering exorbitant and monopolistic prison phone rates. Welcome, Liz. Takunda Matos is an assistant professor of philosophy at Loyola University Chicago and a 2021-22 Edmund J. Safra and Center for Bioethics Joint Fellow in Residence. His work on carceral justice, carceral justice, he defends a rational, egalitarian approach to justice in healthcare and argues that such accounts must take social groups as legitimate units of moral concern. Takunda was also a co-facilitator of the Reciprocal Education and Community Healing, or REACH Coalition, a philosophy group that meets on Tennessee's death row. Welcome, Takunda. Britt White is an organizing fellow at the Institute to End Mass Incarceration at Harvard Law School and the decarceration campaign manager for Live Free. She was a voice for formerly incarcerated women, as well as an organizer, strategist, and trainer. And she centers her work on women and their unique experiences in the American penal system. Britt served 5 years within the Alabama Department of Corrections from 2009 to 2014, giving her firsthand knowledge of the phenomenon of mass incarceration. In her current role as decarceration campaign manager for Live Free, she has expanded her work on reducing incarceration to a national scale, working across the country to empower justice-impacted communities. Welcome, Britt. Finally, William Weber, our moderator for this event, is an emergency physician at the University of Chicago and the National Medical Director of the Medical Justice Alliance. He has consulted for the World Health Organization and works on the Public Health Committee of the American College of Emergency Physicians. Will, the floor is yours.
Thanks, David, and to all you who have come out to this, this presentation. I'm really honored to be here and have the chance to learn from these leaders in the field of medical justice, specifically focused on those who are incarcerated. So I just want to start a little discussing the state of healthcare in prison settings. And I wanted to first discuss a little bit about the structures that are actually involved here. And there are a lot of different settings where people are incarcerated currently in the US, whether it's federal prisons, county jails, or detention centers. And so I first wanted to turn to Liz. So Liz, as an attorney who has worked across these very different settings, would you be willing to just give the audience a brief overview of the relationship between these different settings, specifically in Massachusetts? So like how does, for instance, the Department of Corrections interact with more county jails? And then what is the relation to medical care within the Department of Public Health or Department of Mental Health?
Absolutely. Thank you so much for having me. It's really an honor to be on this panel with all of these experts, and I'm really looking forward to learning from everyone else here today too. So I first want to start just to give with an example, because I think that's an easier way to understand when I break down how the system actually works and how it interacts. I had a very close family member who was incarcerated at Bristol County Jail, which is about an hour south of Boston, on the South Shore, or South Coast, I should say. And she had heard, and unfortunately didn't talk with me beforehand, that being placed in the health services unit and telling them upon admission to be placed in the health services unit would be a good idea. And so that's what she did. And so she ended up in the health services unit, which is where a lot of people come in detoxing or very serious medical issues, including mental health care and mental health crises. On her very first day there, a woman committed suicide while detoxing in the health services unit. And so I say that because when I was able to visit her and ask her why she did that, I said, I would have told you the opposite. That's the worst place to be. And so I wanted to start there because it's a personal story, but also because it shouldn't be that way, right? That it's a dangerous place for you to be when you're coming into the system in the health services unit because of how awful the care is, and also because of the amount of trauma going on there that's going unaddressed. So in terms of the system, that was the county jail, right? The county jails in Massachusetts hold people who are serving less than 2-year sentences for the most part. And I want to highlight something else about the county jail system, which is huge in Massachusetts, talking about 14 facilities across the state. And they hold the majority of the incarcerated population, actually. And the majority of the folks who are in county jails are pretrial, meaning they have not been convicted or sentenced with anything. They're sitting there because they couldn't post bail. And so it's largely people who are unable to post bail and wait outside of the county jail system. And then there's the Department of Correction, which right now has roughly 6,800 people. The numbers have gone down significantly over the past few years, as they have in many other states. And so that system is also spread out across Massachusetts, and those are people who are serving over 2-year felony sentences. In terms of the healthcare, I just want to give a couple of other statistics because it's relevant. In the DOC, the Department of Correction, we have over 1,000 people serving life sentences. And this is relevant because A, it's about 1/6 of the population, which is huge. And also because it is one of the reasons driving are very high percentage of elderly prisoners in Massachusetts vis-a-vis other states. We have right now the second highest percentage of elderly prisoners in the system, and that will continue because of the life sentences until we end life without parole and actually have an effective parole system. In terms of how the healthcare operates, across the board, these are mostly flat rate contracts, meaning there's a disincentive to really provide quality care, right? And so that's one problem. And then the other thing that I wanted to mention is that each county jail has its own contract for health services, for healthcare and mental health care. It's privately contracted out in Massachusetts. The same thing for the Department of Correction. It's a private contract and it's a subcontractor that provides the correctional health care. And then again, it's a flat rate contract for the most part. So there's a disincentive to provide quality care. And again, this is a population that is disproportionately suffering from a number of ailments. In the county jails, you have upwards of 80%, in some places in the 90th percentile of people who are coming in afflicted by substance use and serious mental health issues. In the Department of Correction, what you have is a really high percentage of people in the same boat and also suffering from other chronic illnesses and diseases. So you have essentially a system that is designed and has increasingly become overly punitive with mass incarceration and the explosion of incarceration in the 70s, 80s, and 90s, and really a less of a focus and really a divestment from rehabilitation in these spaces, so that you have at its core, an incredibly punitive system that is supposed to be providing healthcare to a high need population. So I'll stop there.
Thank you. Yeah, you really explained a lot about the different structures within Massachusetts, the disincentives to actually provide good care and rehabilitation. Now, stepping outside, I know we are a little more Massachusetts focused, but for the people who are tuned in, who are from around the rest of the US, would you say this is a somewhat similar setup to other states in terms of flat rate contracts, in terms of mental health provision?
Yeah, so the correctional care providers they're like, huge corporations. They're providing these services at many jails and prisons across the country for the most part. There are some examples of more localized contracts, but for the most part, you can look up any of the contractors and see that they're providing services to prison systems and jail systems across the country. It's worth noting that in Massachusetts, we don't have private prisons yet, and hopefully it stays that way. But there's a little bit of a different relationship sometimes with private prisons, but for the most part, it's the same contractors. And the Bureau of Prisons pretty much does the same thing. There are some jails for the most part, I don't know too many prisons that do this, but some jails that provide the care in-house, meaning that they actually hire directly care providers that will provide the mental health care services and other healthcare services internally. But the standard is still, right, we have legally sanctioned substandard healthcare in prisons and jails, and that is the same everywhere because it's sanctioned by the Constitution. And that is a fundamental problem that I'm sure we'll get into more, but it's incredibly difficult to litigate a prison healthcare case for a number of reasons, and that's because of the way the system is set up. Okay.
Well, thank you for giving us the context. I think understanding the structures at play here are really, really helpful to have the context. But now we also want to ground this discussion in the individual stories, because I think those are really critical to understanding the actual state of healthcare within these settings. And now Britt has been incredibly gracious in her willingness to share. She actually has some firsthand account of her own experience within the carceral system. So I wanted to turn it over to you, Britt. So during your time within the system, what was the experience on the ground of actually obtaining healthcare for yourself or your other friends who were also incarcerated alongside you?
Yeah, so just to provide some context for my experience, I have been incarcerated in every single facility a woman can be held in the state of Alabama. Department of Corrections, the private facility therapeutic, the private jail facility that was like the overflow, the main campus, Julia Tutwiler, and both work releases, Montgomery work release and Birmingham work release. And before you can even talk about seeking treatment, it's important for the audience to understand what the lived experience is for a woman who is incarcerated. So you're predominantly surrounded by concrete and metal, right? All of these elements making your menstrual cycle that much more intense. And so the sleeping conditions and the reality of your day-to-day, not being able to access hygiene products except for what's offered on the store, all have an impact on your health. Your lack of ability to be able to go outside and get fresh air and sun, as your ability begins to take a physical toll for your body. I was only fortunate because I went into the carceral system at the age of 23. So I was relatively young, stayed there until I was like 27, get ready to turn 28. But older women who are going through menopause, people who have physical challenges, have a very different experience. So when you go to seek healthcare, first of all, there is an immediate cost associated with that. In the state of Alabama, you have to pay what is called a sick call fee. So whether your ailment is treated sufficiently or not, you have already paid for a service. Then it is based off of who is available there and what their bedside manner, if you are even believed. And so if I seek the nurse and she's having a bad day and she doesn't believe that I actually have a headache, a cold, or whatever brought me into the room, then there is not like I can go and see another healthcare provider. If anything, she can have me removed by the correctional officers, and then I'm just left to figure it out on my own. I particularly also think about one situation where we had a young lady become infected with staph, and the staph had infected her body so much that she actually died. And what was so mysterious about that situation to me is there was no clear transparency on the Department of Corrections to disclose to her family what had happened. It seemed to be very little accountability. Also, another young lady who I actually came home, but during COVID, she went to go seek healthcare in the Birmingham facility, and they turned her away, according to the young ladies who were incarcerated with her. And because she was turned away, she actually had a headache. I don't know if she had an aneurysm or what exact medical condition, but she ended up dying because she was refused treatment. And so I cannot underscore the vulnerability enough of what it means to have your life predicated on others' bedside manner and ability to believe you. Last thing I'll say, and I'll stop, is there is also something about incarceration that leads you to come home and experience violence in a very unique way. So many ladies that I have been incarcerated with have been victims of domestic violence, have been murdered, or victims of gun violence since they have been home.
Thank you for sharing, Britt. It's heartbreaking to hear these types of stories about patients who really have suffered, who have not gotten the needed medical care they have. And unfortunately, with our work with MGA, we've seen a lot of these similar themes that they're very characteristic of patterns that we've seen across multiple states with many different individuals across the country. And a lot of these themes you talked about in terms of patients in carceral settings aging more quickly. That's very established in the literature, that this does age people more rapidly than typical. We've talked you'd mentioned about there's a cost associated with this, even though they have very little access. There's also this cost, and many people who are in carceral settings is because they don't have access to money, and they may have landed in because they were trying to access money or things like that. Would you, maybe from your perspective, Britt, would you be able to tell in terms of like costs, what are these costs like minimal for patients? What does the actual cost look like compared to the money that patients are able to make while incarcerated?
I can speak only for the state of Alabama. I have been home. This will be my 8th year home. So I can't remember what a sick call is. It's between the $3 to $6 range. But the problem with that is that cost is every single time you drop a sick call. So you think of people who have like a tough menstrual cycle, and you're just dropping this sick call because you would like access to a pain reliever on your time of the month. Well, if you are a person who hasn't received money from your family in years, you don't really have outside connection or support. I have seen people be hundreds of dollars in debt behind sick calls where it's just added up over the years. And the policy at the time I was in the DOC in Alabama is whatever money your outside support sends to you is automatically taken off to redeem your sick calls and bring your balance up to date. So there is a big misconception of what people get access to while in prison, but in the state of Alabama, you have to buy your own soap, your own shampoo, your own deodorant. And then if your hygiene isn't up to par, that is grounds to be reprimanded. So literally taking people's ability to provide for themselves with dignity while in prison. As far as earning income, the only job that I knew that was paid in the main prison was to go work at the sewing factory where they make cents per an hour. Like it's a very minimal fee. So I just really, if this audience walks away with nothing, walk away understanding that the most vulnerable demographic who has no agency in the process to be able to critique or advocate for themselves are being financially taken advantage of by these large medical systems. And it's gross because the conditions that they live in are a festering environment for sickness and disease.
Yeah, thank you for sharing. I think for context, I mean, $3, $5, $6 for a medical visit doesn't sound like a lot for many of us who are not in the system, but there are no federal minimum wage requirements for people who are working within the system. So on average, it is between like as low as 14 cents an hour that you can, like on average, it's around $1 an hour. So if you talk about a $5, $6 copay, that could be nearly a full day's wages for patients who are not being given. Sorry, great. Sounds like you had something to say.
And also, if your grandma is only able to send you $50 a year, that is what, maybe 10 visits, 11 visits to healthcare. So that is how it's getting up, because there's an assumption that people have all of this outside support, but if we're experiencing inflation out here in free society, then you can imagine what inflation looks like in prison. The outside help that their family and support system is able to offer has dwindled.
Yeah. So now we have like a little of the individual stories, and I wanted to kind of zoom out. Now we have Britt's like very powerful perspective of her and many others in Alabama. But Liz, if we zoom out from kind of individual stories, what do you see as kind of more broad trends, both in mental and psychiatric needs, in terms of needs compared to the provision of those services for those who are incarcerated?
Yeah, thanks so much. And thanks, Britt. We definitely have copays here in Massachusetts too, and it's the disincentive to care again for a high need population. And I want to echo something else that Britt mentioned, because it really underscores all of what we're talking about, which is the propensity to not believe the person coming before the healthcare provider, and to discredit this is particularly true for people of color. Just like it is in the community, I think it's even more amplified behind the wall, that you're just not believed and also presumed to be med seeking, drug seeking. And that's, there's a question about that I hope we get to. In terms of the systemic issue, so I guess one example I will give to kind of highlight the level of kind of need that we're talking about. We had to litigate a case against the Department of Correction here in Massachusetts for years, to get very basic access to treatment for people who are Hep C positive. And it took, again, years, so a lot of resources of litigating against the state to do that. And still, we have said, well, we have to do this in the county jails too, which is a more transient population and where the propensity for spread is even higher. But none of the counties provide Hep C treatment to people. And the reason is because they refuse to test for it when someone comes in because they don't want to have to identify so that they don't have to treat it. And this is an example of kind of a systemic problem that plays out for many other kinds of chronic diseases and illnesses. But it's a major public health problem, right? There's no sensible reason for doing that. We are hurting people in the community. We're hurting people inside. We're allowing, communicable diseases to spread, and only doing that because A, of the way that the contracts are set up, and B, because as Britt already laid out super clearly, this is a population that's dehumanized and just not considered, worthy of care. And just kind of going off a point I said before, it's really hard to have, right, a patient-centered care system within a system that centers punishment, right? Like it's just not going to happen. And so there are many, many chronic issues, and I don't think we have to look that much further than COVID even to see what we're talking about, right? This is a most afflicted population in the country in terms of the virulent setting that it is, and people contracting the virus and deaths from COVID. But still, there was a lack of evidence-based practices in these settings, again, because I believe because people just aren't valued in the same way. And so those are just some examples of some chronic issues. Diabetes is a huge problem. Britt already mentioned issues with women. I want to highlight another thing. Here in Massachusetts, we have 76% of women who are incarcerated have open mental health cases. These are women who not only, as Britt said, leave to more trauma, they come in with a lot of trauma, having been victims of domestic violence, having been incarcerated for trying to protect their own lives or the lives of their children. So there is a criminalization of women, particularly women of color, in a trauma issue that really gets exacerbated by incarceration as well. And so we're dealing with major mental health issues. You asked about DPH and DMH before. I'm going to say this, and there are probably people in the audience who will want to disagree with me, but there are regulations in place where DMH and DPH have very explicit authority to regulate the system in some way. But in our perspective at Prisoners Legal Services, in the years we've been doing this work, they have been very hands-off, and for the most part, really, abdicated responsibility for this population. We'd like to see that change, but in effect, there are audits done by DPH. You can look them up online, and violations cited, but no follow-up that you can really see. So I think that is a problem in terms of dealing with a lot of the chronic issues that we see in the system. Sorry, Will, did I answer your question?
Yeah, thank you. So you've talked a little bit more about maybe a lack of oversight here. And Takunda, we have not forgotten about you. We really want to get your perspective as well. So so Takunda, we have Liz has mentioned kind of maybe a lack of oversight, as well as these flat rate contracts and privatization of prisons as some drivers of poor medical care. From your research, are there other factors that really stem from our current conceptualization of healthcare in facilities that lead to more inadequate allocation of health resources?
Yeah, so thank you so much. And I really appreciate being part of this panel and hearing both Britt and Liz talk. And, I want to start out by just, acknowledging once again the men who are on Unit 2, who are part of the Reciprocal Education and Community Healing Program on Tennessee's death row. I do a lot of this work as an advocate for them and also for the countless others who are trapped in the criminal legal system. So I think it's important to just foreground all of them. This is why I appreciate Britt's voice. One of the things I think we should sort of emphasize, I want to start out by reiterating part of what Liz was saying, which is how actually pervasive this is. So by approximately 2008, we were talking about 62% of states and county jail systems that were contracting all of their healthcare out, right? So not providing it in-house. And, again, that was 2008. And this is very, very broadly speaking, the state of the healthcare provision in these contexts. And in addition, there's a factor which I think exacerbates it, and this ties into something that Liz was just talking about, which is, in the early 2000s, by that point, we had a shutdown of most state-provided mental health hospitals, right? And so where are all of those folks being funneled? Well, they're being funneled into the criminal legal system. And so these all become factors where, you're having people already coming in with various kinds of medical conditions, not to talk, about the extent to which a lot of our healthcare infrastructure, just broadly speaking, in society overall, is already very insufficient. It's very inadequate. And so you have people with health needs, health concerns that are coming into these contexts with already, a lot of problems, and then they just get exacerbated within this context. So I'll stop there for a second.
Yeah. We appreciate you bringing in there's a much broader conversation about healthcare in general in the US. And that has a big interplay with people coming into the system. And you have mentioned, or we've talked about how healthcare within the system has a tremendous damaging effect on many who are incarcerated. But now you also have looked at the interplay, the reverse direction in your research. So I was wondering a little bit more to kind of how do you see like this cycle impacting society then, with people getting poor medical care, then potentially coming out of the system?
Yes, thank you. So I think there are actually a few different levels that we should think about this. So one of the areas I work in is in political philosophy. So thinking very broadly about our political systems, but then also our ethical obligations to people. And so most of the people in the audience today are coming from places that are either democratic political systems or republics. And one of the reasons why I want to sort of emphasize that is that when we're thinking about the criminal legal system, when we're thinking about carceral context, it's important to understand that what happens in those contexts is done on our behalf, right? This is what it means to be in democracies, even faulty ones like the ones we live in. So this means we actually have a kind of collective responsibility. And I think it's something that, really needs to be emphasized, because what it means is the failures we're seeing in these systems are failures for our societies, more broadly speaking. A few other things I want to kind of highlight here, and we've already heard this from what both Britt and Liz have already said. So one thing to remember is that people are already socially contextualized before they come into engaging with the criminal legal system, right? So whatever societal problems are happening before we come in, we just bring those into these contexts. But also people remain socially connected. So even if we're thinking about most carceral contexts, and I think the pandemic is a really good example of this, you have people that are on the inside who are regularly interacting with people who are going in and outside of carceral contexts, right? So these include guards, their attorneys, volunteers, other kinds of staff. And so you're constantly having an sort of interchange of the kinds of healthcare concerns that are happening on the inside with what is happening in the rest of society. And I think it's important for us to recognize that there's not a separation. It's not a clear cleavage in terms of that concern. And I'll just kind of, emphasize one other thing, and this has come up a lot in what Britt has been saying already. Because we are socially, situated individuals, we're talking about people who have loved ones, who have parents, children, relatives, friends, people who are coming out of communities, and for those who are fortunate, like Britt, who are being reintroduced back into communities. So, one of the things, again, to kind of reiterate, is that the health concerns here are not being isolated in these carceral contexts. Issues that arise there will continue once people come out. And also, it's important to note that some of the burdens are also being continued or being perpetuated outside of those contexts as all. They're being carried by the people who are not directly in the context, but a lot of people are being impacted much more broadly than just the people in these settings.
Yeah, thank you for sharing that. I think from our own work in MJA, we've seen this happen numerous times, how there's knock-on effects of poor medical care within the carceral system, having big ramifications on the patient's ability to reintegrate into society, to help rebuild that social network that they have. For instance, we had a gentleman who had untreated kidney disease that eventually ended up as kidney failure. And this gentleman, over the course of a couple of years in prison, was now reliant on dialysis. So weekly needed to spend about 3 times a week, at least 3 hours doing dialysis. And that makes it much, much more difficult to hold down a steady job. It makes it much more difficult to care for children or loved ones, family members. So there are these huge ramifications that can happen because of poor medical treatment that have knock-on effects. So now that we talked a little bit about the current problems with health provision, I wanted to discuss briefly about remedies that people currently who are incarcerated, who maybe are not getting the medical or mental health care they need, that they could get. So I was wondering, maybe we could go back to Liz as someone who fights for patients who are not getting appropriate medical care. What types of remedies do those in carceral settings have if their health needs are not addressed right now?
Yeah, thank you for that question. It's a little tough. Well, I think one of the main issues that I think might not be obvious from what I said, I want to make it clear, is that, mere negligence, not mere, is serious, but negligence and malpractice don't give rise to a constitutional violation of care, which is the standard for that is deliberate indifference to a serious medical need. It's a very subjective standard. And so in terms of remedies, there are legal remedies, practical remedies, I'll say our office spends about 40% of our intake resources on advocating for people who are contacting us about healthcare, mental health care needs. And so we'll write advocacy letters, and we're increasingly trying to work with doctors. We have a pro bono medical panel that we work with of different people who have different specialties, where we consult and try and do the best advocacy we can. The problem is that we're advocating to the corrections system and the provider, and there's no oversight over that. There's no other arbiter of that. And so we have a very low success rate for the most part in a lot of that advocacy, because it just depends on the goodwill of the person on the other side and whether or not they care or not, to make sure that that person is getting what they need, right? So people, and I'm sure Britt has experiences with this, but you will go to an appointment, you'll go to an outside specialist, a specialist will say, God, you need this, and that. And then nothing happens. There's no surgery that comes. There's no follow-up on the recommendations because they're not required to do that. And so that's another battle that you have to take on. And so that's just kind of on a practical level. There aren't a lot of remedies. So people file these sick slips that they have to pay for the most part. And then if you're not getting the care, you can file a grievance. And this is all internal process, or you can file a grievance. And then there's a process around that. So they're supposed to respond to your grievance as an internal kind of grievance coordinator on the medical side of things that looks at that here in Massachusetts. By and large, they're rubber stamped, but there are, cases where certainly corrections will step in and say, get this person their medical shoes, or get this person their bottom bunk because of back problem, or those kinds of things do happen. But for the more serious issues, what we have seen is that people need to litigate. And for folks who are inside, we are a very small office. We maybe litigate 1 or 2 healthcare cases at a time if we're lucky to have the resources to do that. For people to do it on their own, which is called a pro se lawsuit, is extremely difficult. I mean, it's difficult for any of us to try and navigate the legal system on our own, even as a lawyer. But behind the wall, with all of the issues that what we've been talking about in terms of mental health and physical health and literacy problems and mail, just being able to communicate, you can pick up the phone and just call someone. The court's not equipped to take calls from prisoners. Like, there's all these barriers to just being able to access legal remedies in the courts. And then if that weren't enough, you need to go in Massachusetts through a medical tribunal, and there's no way you will ever win a case without a medical expert. So if you can't pay for that, then you are out of luck. And there's a disincentive for even firms to take these cases because there's something called the Prison Litigation Reform Act, which limits the amount that you can collect from these cases. And so there's no incentive for people to take these cases, financial incentive anyway, or very, very limited anyway. So that's just kind of in a nutshell, the sad story on remedies. But I have some ideas for, maybe how we can.
Yeah. I've seen Britt. I saw so much head shaking and head nodding. You certainly have something to say.
Yeah, I think particularly for the State Department of Corrections, it's like, who is accountable if all else fails? Is the governor. You're talking about making a plea directly to these governors who basically like these state facilities report to. And the problem is that political ideology and human worth looks so different across our country that there is no blanket answer to begin to build out accountability. And it's part of the deep frustration that exists within the system. Is not only is your inherent value being denied, but there is no accountability, and it's very difficult to get your message out to the world. The pictures that I have received from different institutions during COVID have just been literally heartbreaking. You're talking about people who are being housed in facilities at the beginning of the pandemic with people who have symptoms that they don't understand, because also the same type of public education we get around healthcare from the news and different sources is not necessarily being translated or being instituted behind the wall. And so it is, as someone, my biggest challenges that I had as far as my own personal healthcare was my teeth. I am going to have to spend thousands of dollars getting my teeth repaired just from the 5 years I spent in prison, because unless you have the money on your books to go outside to a free world dentist, the dentists in prison told us the only thing they do is pull teeth. That is solely what the service that they're able to offer. As a young woman and as a feminine woman, I was concerned about my appearance and didn't want to lose my teeth, but it ended up happening. That's a very small act compared to the other things, like people who have lost their lives from the neglect, but the system as a whole has no transparency. If you drop a grievance, it's going to the sergeant or the warden based off of your behavior. They're going to consider, is it even valid?
Yeah, thank you so much for sharing about that. It is really difficult when there's little oversight, as Liz had mentioned before, when it's it's extremely cost prohibitive for cases to be brought up. One, because there's not much incentive for legal firms to take these cases. And as Liz is mentioning, if you're trying to get a judge to listen to it, it's hard for a lawyer to convince the judge about medical matters. And this is part of the reason, it's a shameless plug, but Medical Justice Alliance is doing work to try to get expert witnesses as physicians who volunteer to do these expert witness papers, because typically an expert witness physician will cost around $400 an hour. And that's just not feasible for nearly anyone who's incarcerated to pay. And legal firms can't pay that. So it's really difficult. There's such a high barrier to getting oversight with these. I want to go back to Kunda a little bit. I know we talked a lot about the different issues kind of from an ethical standpoint. And so from maybe your bioethics standpoint, where does the US fall, or how do they fare compared to other developed countries in terms of the care provided within carceral settings?
Very poorly, which I'm sure is not a surprise to most of us. But I think here's one place I will say, actually, the US has done a fairly good job, which is from the kind of advent of bioethics as a discipline. One of the key acknowledgements was that the very fact of incarceration places someone in a position of vulnerability. So this has been codified in the US federal regulations regarding research with people. And so people in carceral contexts are classified as vulnerable. Unfortunately, that's sort of where the kind of bioethical thinking has pretty much stopped. Once people in this context were seen as, once they're not seen as research subjects, there's not much of the ethical thinking that's gone on there. And this also kind of mirrors the way that people in these contexts are treated more broadly in the healthcare systems. And part of that has to do, and I hope we keep talking about this during our time together. Part of that has to do with just the fact that our healthcare system more broadly in the United States is not very integrated, it's not very comprehensive. But there has been a push in, especially with the WHO, to really, advance this idea that healthcare in carceral contexts should be part of just broader social healthcare systems. And I think that's something that we should do more of, we should try to pursue, instead of sort of seeing this as a problem that's isolated to a context that we don't have to really engage with. But unfortunately, as things stand, that part hasn't really happened. But again, other countries are doing a much better job of this. The US just is really, really bad at this. And I just want to add one other thing real quick. Part of this has to do with the rationale behind most of the healthcare that's provided in those contexts, where the emphasis is on kind of infection control and not on other aspects of health and other aspects of healthcare that are really, really important, especially if we're thinking about the whole person. But even on infection control, and we saw this in the pandemic, there was one point where the 5 largest clusters of COVID-19 infection were in carceral context, right? And so even on that point, we're not really doing well, even though we highlight that and neglect mental health and sort of elderly care and dental care and all of these other things.
Yeah, I appreciate you bringing up, at least there is one small bright spot within the US criminal legal system in terms of this has been codified, and the Supreme Court has held that it is cruel and unusual punishment to withhold appropriate medical care from patients. So it's something off of which to build, but as you were mentioning, this is not this is turned into a system where those ideals are not realized. And I know Britt had mentioned about teeth pulling, and I know Jennifer and many people in the questions and answers have mentioned, like, this is a very reactive thing. They're just pulling teeth. They're just reacting to things after it's gotten bad. And that's not appropriate medical care. And I know both Josephine and Catherine also had mentioned in question and answered about, like, both individuals who have been hurt by that, and that because there's this perverse incentive, a lot of times medical providers in carceral systems don't have the resources needed. They don't have enough workforce, and so they end up just trying to fight fires. So I appreciate you bringing that up.
Well, can I just before we transition, can I just add one more thing? I'm so sorry. I think it's also important to note that about at least 3 times I was waking up in the middle of the night and had my blood taken, and I have no idea where my blood was sent to or tested across the country. And that experience is not unique to me. Other formerly incarcerated people who have been in the feds and the state have mysteriously had our blood and our DNA taken and sent out very early in the morning. So not only are we preyed upon by the medical system, but somehow we've become research that is being used to bring about whatever testing or results is coming about. So I think it's 2 prongs of this situation that should be examined, not only how we're preyed upon, but also how we are essentially lab rats to further along medical breakthroughs as well.
Yeah, I appreciate you mentioning that. And I think it's especially acknowledging the disproportionate number of people who are people of color who are incarcerated, and the unfortunate medical history of experimentation on people of color. I think those are that's a very important context to understand, and really tragic for the history. Actually, I think Takunda had a little bit more. Multiple people have mentioned that people who are incarcerated are actually the only people in America who have a guaranteed constitutional right to medical care. And that this is one of the places that Liz and other attorneys have used to try to fight for people's rights. And I think Takunda had some comments on that.
Yeah, and I don't know if Liz wants to actually get more into details about what that is and the Supreme Court rulings, but I think it's worth pointing out that, so I think that's a good feature of what healthcare in the US is, but it actually amounts to just a sort of formal right and a formal protection, and not an effective or actual protection. And this causes problems in certain cases. I just wanted to highlight sort of 2 instances, 2 types of cases where this thing which is meant to be good is actually often weaponized. So one instance is, so sometimes law enforcement personnel will accompany people to emergency rooms, continue to be engaging in sort of investigative data gathering during that phase, but not actually proceed with the arrest. And in part, that's because of this right. And so they don't want to be responsible for paying for the care, but they sort of weaponize that opportunity, which, I know we're going to talk about physicians and their role a little bit later, but that complicates the provision of care. And then the other thing, and this came up during the pandemic, where one of the fascinating things that happened is lots of carceral institutions decided it was suddenly okay to release people. And it was portrayed as compassionate care, compassionate release. But there is this worry about whether one of the motivations for doing this was to avoid providing healthcare to people, given this requirement to pay for that care. So I just wanted to sort of add that.
Did you want me to jump in, or do we want to transition? Up to you.
If you had anything else to say, otherwise we can
Oh, just
transition.
I mean, I totally agree, Professor Motosi. That is, yeah, it's really, it sounds like we've got this constitutional right, and that's great, but it's really, it's such a floor and minimal floor. In that, like I said, like negligence and regular malpractice are not enough to get you to that constitutional floor. But also, I think this is a good opportunity to highlight what Brett was raising before too about oversight, because litigation is an important mechanism for accountability, certainly, but right, the large majority of people incarcerated will never be able to file a lawsuit. It's a Prisoners Legal Services Massachusetts, and we can take a tiny percentage of all kinds of cases, brutality cases, solitary cases. There are a million different kinds of cases that come to our attention. Healthcare is one of them. And there are many states that don't have access to legal services. So that can't be the accountability mechanism that we rely on, right? It's gotta be, as Rick was saying, our state, our governor, executive offices that hold these agencies accountable and don't let them fall below the floor at the very least.
Yeah, so I appreciate everyone's perspectives on this. I mean, we clearly see that there is constitutional right. We clearly see that this is not being lived out, and that even people whose constitutional right is being violated so often are not able to pursue that and to get justice for themselves, which is part of the reason we've often referred to as the criminal legal system rather than the criminal justice system. I know so far we've talked a little bit more about the dire side of this system. And I would love to turn to these panelists who have really thought deeply about how the system could be instead, and talk a little bit more about what a more just approach would look like for the US. I think maybe we can start with you, Takunda. You wrote a whole PhD dissertation focused on justice and healthcare. And so as someone who's really explored this topic at length, what would be your vision for a more ethical system of care within the US?
Yes, thank you. So I think one starting point is something we've actually been touching on throughout this conversation, right? And the starting point is recognition of the fact that we have individuals who are entangled in the criminal legal system, but they're still human. And one of the things about being human is we are very social animals. And so one of the things I talk about in the dissertation and in my continuing research in this area is the idea that health is an importantly social concept, right? So it has various social dimensions. So, you know, and I think it's important to think also just about the criminal legal system as a failure in societal responsibility instead of individual failures. So that's part of the work here, is to think about health as something that, you know, if we have societal failures, that leads to breakdown in personal health and breakdowns in our healthcare systems. But health is also something we pursue for social reasons. We care about our relationships, and, you know, people in carceral contexts continue to be in communities and continue to be connected to other people. So, you know, I'll just plug one of the pieces I've worked on with Abu Ali Rahman, who is one of the insiders at Riverbend. And we have worked on that with Elizabeth Lanphier as well. And we talk about the notion of habilitation. So thinking about what are the structures outside of carceral context that need to do the kind of scaffolding, both for health and other social purposes, where if we build up a robust enough system of structures before people even encounter the criminal legal system, then we can actually get to a point of really abolishing the criminal legal system, because in many ways we get rid of the need for that. But also for the people who are in these contexts, we need to think about how we are treating the entire social being. because they're in communities in those contexts, they have to deal with each other. And then we need to move again from sort of treatment of acute illnesses, thinking more about preventative care and holistic care, and then continuing that once people re-enter communities, equipping communities to be able to take care of people, both who are already there and people who might be coming out of entanglement with the criminal legal system. So that was very quick and very broad, but again, focus on the social, the whole social being. And I think that's a start.
Yeah. I appreciate you sharing that. And I think there are so many parallels to even the medical care we get that people are getting in while they're incarcerated. So your idea is are we doing preventative care to help people avoid the system, get the resources they need to avoid the system? In the same way, like, are we doing dental care within the carceral system to avoid pulling teeth, right? So there are a lot of similarities. And I know, Britt, you also have a very unique perspective as someone both with firsthand experience within the system and now working and helping to lead a faith-based nonprofit that has helped reshaping the whole system. I was wondering, would you be willing to share a little bit more about how do you envision the system and like shifting or changing, and how does your faith perspective inform that vision for what the criminal legal system could look like?
Yeah, I think, like a good Black preacher, I have 3 points to that, even though I'm not a preacher. First and foremost, like, prison taught me to be cold and shut down. I appreciate the fact that Takunda is talking so much about the connection, because that is actually what is policed most. Fraternizing is banned in prisons and jails, but the need for connection, the human need for connection, is real. And so I experienced the death of my grandmother, my great-grandmother, and my uncle while I was incarcerated, as well as a couple friends. And the process of grief taught me to go within myself, because I could not act out or lash out or grieve in the environment of incarceration without being penalized. And so what does it look like for me to come home from prison actually warmer, or actually healed, or with tools? Like, organizing has given me a sense of tools to process my emotions. It has taught me to advocate for myself. It has put me in connection with people who deeply care about my well-being. I wish that I could give that to people in prison, because prison is currently functioning out of what we call a spirit of scarcity, right? That teaches you about less. And I would like to flip that on the head and think about what it could be to offer a spirit of abundance to people in prison and let them know the trauma that they have experienced, there is healing and connection in people who actually care about them. Many of the folks who end up going to prison have grown up without their socioeconomical needs being met. They went to some of the worst education systems. They have not had access to healthy food most of their life, and may have not even had access to like a coat. Just poverty is a big factor in shame. And that shame is perpetuated and it festers in the environment of prison, because it teaches you, the system constantly reinforces that you are wrong and you are worthless. And that does not position people to advocate for themselves and their health, mentally and physically, but it also does not put them in a great position to go back into society and be successful. Last point I'll end with is this: I had to reestablish my relationship with my family and friends, because my emotions have been cut off for so long, and I have been disappointed so much that even being able to socially interact with the people who I knew loved me the most was difficult. The other thing is, your girl came home and gained like a good 75 pounds in the first 2 years, just because I had not been able, I have felt like I was in a constant state of starvation for 5 years, being in so much food insecurity, that I literally came home and ate everything, and I'm paying the price for it now. So I just think that we have to completely do a 180 in how we value, and that we have to make the criminal legal system about healing and redeeming people, instead of casting them away and putting folks out of sight who we don't know how to help.
Yeah. Well, we so appreciate both Takunda and Britt, your visions for what it could be, of this idea of moving from this place of scarcity where you don't have resources, where you are concerned about food, and from like an ethical, moral, spiritual standpoint, to a place of abundance where the US is providing these people support, they're providing social needs, they're providing social interactions that help them better reintegrate into society. So, and I've seen how all three, both Liz, Takunda, and Britt, are working towards a better system that would be able to do those things. Now, I also want to acknowledge that we currently are at this place of scarcity within the system. We're at a place of not providing for people. And I want to maybe transition it a little bit more into some tangible takeaways for physicians or other people who are working within this system of scarcity. Now, what are some tangible steps that individuals can take in trying to move the criminal legal system in a better way, and especially for physicians who may be taking care of people who are justice involved, not specifically in prison settings, but also in clinics as they're coming to the ER, getting other care? Are there ways that physicians can help move that needle? I'm leaving it open to all three of you.
Yeah, I'll jump in. I have a few thoughts on that. So I think some very kind of practical things that can be done now. Many states have compassionate release laws. Massachusetts just passed one and joined the majority of states in the country just a few years ago in 2018. It's called medical parole here. There are major issues with implementation that we are working on with the legislature to close some major gaps in the law. But for the most part, what it is that people who are permanently incapacitated physically or cognitively, or within 18 months of prognosis of dying as a result of a terminal illness, can petition to be released on medical parole. So that is one way that people can get involved, is to get people, especially in those conditions, out of the system, because it is so ill-equipped to really handle that level of care. And these are people who are in the end stages and who are in very critical need of dignity while dying. And so that is one area that will be extremely helpful. We work on those cases, others do in Massachusetts as well, and we'd be happy to connect with folks on that. I think another area, though, is, I think this panel is a good example, but really putting resources, names about like Harvard and other major institutions behind naming this as a health equity issue, and really elevating that and centering it in public health conversations. Oftentimes we see conversations or measures being implemented or discussed that are focused on public health that completely leave out the incarceration. And so I think centering health equity in those discussions, and in specifically talking about people who are incarcerated, are formerly incarcerated, and in need of more attention and services would be incredibly helpful. And then, as others already mentioned, there's a lot that needs to be done on the ground now. I do think that an infusion of resources temporarily is necessary, and the sort of abundance example that Britt gave is great. It should be completely inverted. We have barely 3% of the entire budget of the Department of Correction being spent on rehabilitation programming. So that tells you something right there, right? That's an incredibly small amount of money that is being invested in people's needs, right? So that I think that is something that we can push for. And then there are a couple of things, I think policy-wise that could be done as well. One is, right, we can divert people like right now. Like we don't think we have to wait until we've got this kind of system in the future. Like right now, there are people majority again of people who are going in with really acute substance use issues and acute mental health issues, really people who are untreated mental health issues who of course then self-medicating and on. So that there's that whole issue that we've been talking about, but funneling people into incarceration and trying to treat them there makes no sense. It's much more expensive. It's a counter intuitive place to be treating people And it's countertherapeutic. So there's all kinds of reasons why we should be diverting people from incarceration and investing more in community-based resources and treatment and meeting people's needs there, and not putting them in the carceral system where it's much more expensive to do that. So I wanted to put that out there too. And there are a number of measures pending in the legislature right now that are trying to chip away at some of that, that we could work with folks on.
I would add to that, Liz, that I think there has to be a, a financial investment in rural healthcare systems, being that most of these facilities are located near rural areas. So if a major procedure happens, you're going to the closest medical system, and are they yet equipped to handle these patients? And we have found out in COVID that outside of the prison, just the rural medical system in town is pretty raggedy, right? The other thing that I would like to throw a curveball to this group and say that public health has to be a neutral entity of oversight for medical practices and medical treatment within the carceral system in America. That we cannot rely on whatever political ideology is ruling us at the time to value human life, but it should live in public health departments to constantly be inspecting these facilities, evaluating these cases, interviewing the people who are incarcerated in these facilities to find out, are people getting the medical treatment that they deserve? This is I won't say it's a simple, but it's a very tangible solution that can be implemented at every level of incarceration in America with the right support. And with the esteemed colleagues who are present in this panel making that ask to policymakers and other medical colleagues, we could make this happen. And that would be the best solution to begin to build in oversight. We cannot leave it to the government itself.
Totally agree.
Thank you guys.
Sorry.
Yeah, do you want to speak? Yeah, we'll let you answer quick, and then we also want to get to some of these questions. People have been putting so many amazing questions in the chat. We will try to get to as many as we can.
Right. Yeah, so just real quick, both what Liz and Britt have said, this is really already being spearheaded in at sort of the international public health level, where they are talking about how, we in some ways we actually need to get rid of the idea of carceral healthcare. But what that means is having a much more solid commitment to general healthcare systems, right? Societal healthcare systems. And that's where the US really needs to invest a lot more resources into.
Yeah. Thank you. Yeah, thank you all for sharing about that. I think there's so many systemic issues that we can address as a society, and the things that individual physicians can bring up. I know from my own personal practice, I think realizing that patients, this may be patients only, if someone's brought in from a carceral setting, this may be the only interaction they have with a physician who will think deeply about their case, will provide them really compassionate care. So trying to emphasize empathy, bedside manner, trying to listen to them, explaining questions really well, making sure you answer all their things, because they're, unlike the average person, they're not going to be able to look up their medical records after the fact. And then being very specific in your recommendations, even prescribing over-the-counter medications. If you know they're going to need Tylenol or ibuprofen, prescribing it, because then it will make it more likely that they can get those medications instead of having to buy them from commissary. So I wanted to get to some of the questions. And I know Catherine had mentioned in the chat about issues of how clinicians are actually recruited to work in carceral spaces. And maybe one of you guys would be willing to talk a little bit more about this. Her concern was, it seemed like a lot of times there is a very, very high pay, which makes it harder to turn down, even if you don't believe in the mission of carceral healthcare and you maybe just go in to try to get money. And a lot of times there are fewer requirements in terms of board certification, things like that. And that there may be concerns about, it makes it very difficult for them to do whistleblowing or things like that, especially if it's their employer. Is anyone willing to talk a little bit about any issues with hiring people within the carceral system?
Yeah, I mean, I'm happy to say just generally, it is really hard to fill these positions, and there are shortages that are problematic. There's also, there are great people who work in healthcare, and I don't want my comments to come off as being, totally one-dimensional. There are great people who care about people who work in corrections and in the healthcare systems too. But you also have people who really shouldn't be there and are really not qualified to be doing what they're doing. And we have like horrific story after horrific story of one person who has amputated the wrong limb on multiple clients repeatedly and still can't get rid of that person, that kind of thing. And you've heard stories from other places. But so it is hard to recruit for these positions. That's probably why the pay is that high and why the requirements, the criteria is low. But they're sorely needed. And so I don't think anyone who's got a good heart and really wants to do this work should be dissuaded from doing the work, because people are needed in these positions. However, it's another reason, right? Instead of spending so much money and so much energy trying to funnel people into this system nobody wants to work in because it doesn't work, we should be funneling people out of the system and diverting people from incarceration, reducing the carceral footprint, and doing a better job of meeting people's needs in the community in the first place. Because it's like reform is reforms, right? We can keep kind of tinkering at the edges and investing more resources, but if ultimately you have a security system that's in charge of healthcare, you're just not going to get there. And that's my 2 cents. But
yeah, thank you for bringing up those points. That is a place, if you have a deep heart, deep care for patients, and you want to serve really underserved patients, if you're willing to work in a carceral setting, that you can make a huge impact. And it is, they're limited resources, but we need more caring physicians in these settings. So, I want to turn to another question we got from Jeffrey. He had brought up the idea that this is a very unique population, and there are concerns from some clinicians that people might seek out medical care as a way to get secondary gain, whether to get out of the system temporarily, whether to just escape from solitary confinement for the time being. How do you guys in your practice approach this? Do you find that these patients who are seeking medical care are typically doing it for secondary gain, and how do you disentangle what's helpful versus not?
First of all, I appreciate him being bold enough to ask that question, because I'm sure there's many people in the audience who are wondering the same thing. So thank you for your question. Number one, I would say that there is probably a very small percentage, I won't erase the fact that this is a legitimate concern, who are weaponizing medical care for their own benefit. But consider the fact that they don't have many tools to advocate for themselves. So even using medical may not be a malicious act. It may be one of the few tools that they see to find refuge in a very oppressive, dark system. Number two, that I don't find it helpful to approach care with suspicion, that people are seeking care in a malicious way in order to, as stated before, advocate within a very dark system. We should look at people and give them the assumption of dignity that they are just trying to be well. And for those who may be using the system maliciously, it will come out, it will be documented in their jacket as people who are, as they continue to be incarcerated with the beam. But I really encourage people to assume good intent, that these are people within the system whether they're trying to, in the streets, we say finesse the system or not, we should assume that they're just trying to be well.
Yeah.
I appreciate you bringing that up. Yeah, and it is, I mean, for people who don't have access, if the only medical provider you see maybe doesn't trust you or doesn't work with you, sometimes people will try to seek out just to get care elsewhere, to have a second opinion, more or less. And it's something that people who are outside of the system have the luxury of being able to seek a second opinion, but otherwise it's really difficult if you're within. Now, there was one quick question in the chat from Constantine, and he brought up a really great point. So he had talked about, we can have physician expert witnesses who can write about the care. And Constantine asked about other specialties, whether it's within bioethics. Are there other ways for people with specialized training to write expert witness testimony for cases like this? And I want to encourage you, whatever walk of life you are coming from, I think there are huge opportunities for you to get involved, whether it's writing, from an ethical standpoint. I mean, Medical Justice Alliance has a bioanthropologist who studies bone density, and she is an outstanding person in the field. And she's actually currently writing for a case where a prison is keeping people in solitary confinement for long periods of time. And she's writing about how that can affect their bone density and cause damage later in life. So there are lots of different ways to get involved. Don't shy away just because you don't have a medical degree. I wanted to bring up a really great question that Jennifer had brought up in the chat. She had talked about specific ways for are there specific ways that hospitals and clinics can help protect patients from police or ICE if they're brought in alongside them? I know we had talked a little bit before how sometimes this can be weaponized. So I was wondering if one of the panelists would be willing to discuss, are there specific ways that physicians or other healthcare providers can help protect patient rights if they are in custody?
I can offer some suggestions. I think this is really hard. I'm sure hopefully others have ideas too. But one thing I also wanted to add to kind of the med seeking question is that there's very little treatment for substance use offered in a lot of prisons and jails. And the data has shown that once you do that, there is less kind of abuse of medications. But I do want to underscore kind of Britt's first answer, which was there's very few people who are really trying to do that. We have seen time and again with our advocacy that someone's being assumed to have drug-seeking behavior when they've never been addicted to drugs before. So I think that's an important question because that is a big problem. In terms of the other question, I was actually engaging with folks at Boston Medical Center about this because they were asking, what can they do? And this is in the context of people coming in very sick from COVID. And in Massachusetts, you have 2 correctional officers that come in, even if you're, stuck in a bed and not a threat to anyone. You have correctional officers that are there by the bedside all the time, and oftentimes will not allow the person to be unshackled, and there's all of these things. But I think there's a perception that the hospital has to follow the DOC's policy or the correctional policy, and they don't think that is necessarily the case because it's not, policies are not laws. The hospital may have a policy that says we follow the DOC's policy, and that can be changed. You can have your own patient rights that apply to that particular situation. And I don't think, and I think there was some research done on this, I'd have to go back and look, I don't think that there is any legal reason why you have to defer to corrections for something that's really counter therapeutic and not clinically indicated for that moment. And so that's one thing I just wanted to offer up, is that if folks look at their internal policies and see that it's just a deference policy, I would encourage folks to take a look at that and revise the policies to be more client patient centered. Sorry.
Yeah, and I just want to second that real quick. I had a case that I consulted on many years ago at the clinical center at the National Institutes of Health, which is, it's basically just a hospital. And one of the things that you realize in those cases is that the clinical institution actually has a lot of agency, a lot of leeway. And so the focus, and this is part of why we should, as we've been saying, we should move all of this healthcare out of the hands of correctional capacities, in part because the focus should just be on the patient. The focus should be on health. And really there is a lot of leeway to do that, but it is a matter of policy and being sort of feeling empowered to pursue the best interest of the patient.
Yeah, I appreciate it. There was Sarah in the chat also brought up the topic of, for those who are currently serving people in correctional facilities, and there's a difficulty in where if you are raising concerns that can compromise your own access to serving patients in the prison, whether that means you're let go, whether it means you're not able to provide. They've talked about, this has been written about in the ethical literature in terms of what's called dual loyalty, where physicians are first and foremost tasked with caring for patients. But if your employer is trying to cut costs, is trying to make sure that they don't get in trouble, you are put in a very difficult ethical position. So I think we're getting very close to the end, and I want to be respectful of everyone's time. I so appreciate all these questions. There was one other question from India specifically, from Lisette actually, about advocating for medical schools to include more discussion of this in their curriculum. And I think that's a huge area where we can grow as within the medical system in terms of teaching our young physicians and old physicians how to best care for people who are justice involved. Medical Justice Alliance, again, this is a shameless plug, but Medical Justice Alliance does do lectures for medical students or hospitals. If anyone is involved with medical schools, medical education, we are more than happy to come by. Just drop me an email and we can work something out. And with that, I think unfortunately, we were not able to get to all the questions. I think this is really important information. If you have questions still, you feel free to reach out to any of us by email, and we'd be happy to talk more at length. With that, I wanted to thank all the speakers for coming, and I want to turn it back over to David to close us out.
Yes, thank you so much for this amazing conversation that we really must continue. We at the Edgerman J. Safra Center for Ethics and the Justice, Health, and Democracy Impact Initiative thank each of our panelists, Liz Matos, Takunda Matos, and Britt White, and our moderator, Will Weber. And we also thank our Harvard co-sponsors, Harvard FXB, the Petrie-Flom Center, and the Office of Equity, Diversity, Inclusion, and Belonging. We also thank each of you in the audience for joining us today. Please be on the lookout panel in the Medical Justice and the Carceral State series, which will be announced soon by Petrie-Flom. Take care.